All right, maybe we'll get started. So I'm sure we'll probably have a few more people arrive, but it's my great pleasure to introduce and facilitate the webinar today. I think we have a pretty outstanding set of talks, maybe mine is accepted, but we're really gonna delve into what we've topicked Genomics 101 and hopefully provide a really good overview for everyone about some current important topics related to genetics and genomics. And to get the ball rolling, I'm very happy to introduce Lauren Brady, who is a genetic counselor at McMaster, specializing in neuromuscular and neurometabolic diseases, and really one of the leaders in the field of genetic counseling for neuromuscular disorders. So it's a great pleasure to have her talk to us about genetic counseling and its role in genetic testing for neuromuscular diseases. So Lauren.
Okay, can everyone see my slides okay? Okay, so thank you for the introduction. So my name is Lauren, and I am the genetic counselor in the Neuromuscular clinic at McMaster, and it's a role that I've been in for about 8 years now. And just some disclosures, I have received honoraria from both Sanofi and Biogen. So what is genetic counseling? What is it that we do? Lots of different roles, but the definition I like the best is from the website for the Hospital of Sick Children. The practice of genetic counseling is to assist individuals and families in comprehending the natural history of genetic and congenital conditions. And this includes talking about the reproductive implications as well as the psychosocial aspect. Genetic counseling often involves talking about the risk of recurrence. So what's the chance for a couple to have another child with the condition that they may already have a child with? And what does that inheritance pattern mean? What are the available testing options? Assistance with the interpretation of the genetic results and sort of making it understandable in layman's terms, as well as helping with management of that condition and options for prenatal diagnosis if the couple finds themselves in that situation where they want to have more children. So the genetic counseling piece really starts before a genetic test is even ordered. So there is a fair amount of counseling that happens beforehand, and the depth of the genetic counseling kind of depends on how engaged, I guess, that the patient is. There are some patients who just say, it's a blood test and I'll just do it and, we'll talk about the results later. But for a lot of people, it's their first time ever doing a genetic test. They've never done a genetic test before, and it sounds sort of different and it can be a little bit scary. So I try to normalize it as much as possible for them by just sort of talking about the practical piece of the test. So, things like who's giving the sample? Are we just testing the person who has the condition, or is this the type of test where we need to get a sample from mom and dad as well at the same time to help with interpretation of the results? What exactly is it that we're looking for? Are we doing a test that looks at, 20,000 different genes, or are we doing a smaller test looking just for, 90 genes associated with muscular dystrophies? Is it going to be on blood? Do we need a muscle sample for that testing? What could the results tell them? When are we taking the blood sample? Do we need to get approval for the test first? When are we going to get the results back? I actually find I always try to mention where the sample is going. People seem to remember where their sample goes, if it goes to Germany or if it goes to Calgary, which can be helpful if other family members get testing done, because they can say, I have no idea what was tested for, but I know the sample went to Germany. And that can be helpful in kind of trying to pinpoint and narrow down what testing was done. We have a discussion about why we're doing the genetic test. And of course, one of the things that people are most concerned about is how long the results are going to take to come back. Some people are usually people are pretty surprised when we say it's going to take a couple of months, because normally when people give blood sample, they are very used to it coming back very quickly. But people also want to know how the results are going to be disclosed. Are we going to have a follow-up appointment with them? Are we going to talk over the phone? Or are we just going to send them a letter in the mail to let them know? So the other part that I always like to tell people beforehand is when someone thinks of genetic testing, they kind of think, okay, the test is going to tell me if I have this condition or if I don't have this condition. But it's not just a matter of positive and negative results, as I'm sure many of us know. Oftentimes when we do genetic testing, we get these pesky variants of uncertain significance, which I can explain to patients as inconclusive results. These variants, we found a variant in a gene that we haven't seen before, and just because there was a variant in a gene doesn't mean it's causing anything. But people aren't usually expecting that there can be inconclusive results when it comes to genetic testing. So letting them know about that ahead of time, often, so when we have the follow-up appointment, they're expecting that. So they know that inconclusive result is a possibility, so they don't end up disappointed that or confused about the results that come back. Usually I'll let people know ahead of time that if there's an inconclusive result, we're going to talk about it. We're going to lead you through the next steps, but we might have to do more testing. We might have to get other family members involved to help us understand these results, but we're going to walk through them. Now, one of the things that is, I guess, comes up a lot in genetic counseling is oftentimes people, when we're doing a test called whole exome sequencing, which I know that Kim's going to be talking about probably in the next section, we're not just focusing in on 90 genes associated with muscular dystrophy. We're looking at multiple genes. So we're going to be covering a lot of information, maybe not related to the, what's going on with that person. So there are a lot of things that can be found when we do that further genomic testing that maybe the person wasn't expecting to see. So these are called secondary findings. And like I said, this really applies mostly to whole exome sequencing. So a secondary finding, for example, you're doing genetic testing for someone who's expected to have an underlying myopathy. And it turns out that they are also at increased risk of breast and ovarian cancer because you found a pathogenic variant in the BRCA1 gene. Now, there is a process to go through beforehand, whether or not somebody wants to learn about these secondary findings. So part of the consent process for certain tests, like whole exome sequencing, is to discuss this in detail and ask the question, do you want to know this extra information? Now, the list is pre-curated of the different genes that you can get extra information about. It's created by the American College of Medical Genetics, and everything on that list is actionable. So, it has to do with hereditary cancer syndromes, cardiomyopathies, arrhythmias, malignant hyperthermia. So if somebody knew that they had a pathogenic or likely pathogenic variant in one of these genes, and that they were indeed at an increased risk for, let's say, breast or ovarian cancer, there's certain screening that would be done. Now, the important thing that I always talk about with families, especially if it's a child who's the main one who's going through whole exome sequencing, is that the list is the list. So for some of the things on that list, the screening might start in childhood. There are a lot of childhood onset conditions included on there. However, some of the conditions on that list, like breast and ovarian cancer syndrome with BRCA1 and BRCA2 genes, you wouldn't start the screening until later on. So if you're talking, I just had this conversation with a family today where, we're talking about doing this test for a 2-month-old baby, and, telling the parents, are you okay with knowing that this little girl could be at increased risk for these conditions, for, let's say, breast and ovarian cancer, but not actually start screening for 20+ years, okay? In that case, the parents actually opted out, but it's definitely a very important conversation to have, and it's not always something that people think of when it comes to genetic testing. Now, the post-test counseling when it comes to genetic testing is sort of hard to summarize. You know, it's very dependent on the results that you get. So if you're talking about a variant of uncertain significance, or if you're talking about, you know, finding a diagnosis, it can be quite different. At least in our own clinic, we have a general policy that, especially if there's a variant of uncertain significance, and usually even if there is a positive result, the physician who I work with, Dr. Tarnopolsky, will often re-examine the patient before we disclose the results. That's just to see them back and kind of look to see and make sure, you know, are we seeing the pattern of muscle weakness that we would expect to see with this condition? Or are we not? And, you know, and so basically the conversation can be tailored not only to the genetic result, but to that person and, you know, their muscle strength and where they're at that point. You know, it's important to cover what the impact of that result is for that person. Going through the result in detail, explaining what the result means. I always make sure that I give a copy of the result if we have identified a definite diagnosis, and sort of break it down so that they can go home and they bring this piece of paper home to their, you know, family members. They're going to be able to explain it and understand at least the basics of it and what the result is telling. We will also talk about the impact of family members. So if we find something like a diagnosis of myotonic dystrophy type 1, you know, there are other family members that could be at risk. Who might need to be tested? Who might need to undergo screening? And how is that person going to disclose this information to those family members? A lot of times I will write patient letters. So a letter that kind of summarizes that person's diagnosis and their results that they can give to other family members that kind of help to explain what they've been diagnosed with and how to get screening for themselves. So the onus doesn't fall directly on that person to remember all the details and convey all the information accurately to their family members. They're able to just sort of, you know, kind of introduce the idea to them, give them the letter, and then that person can take that letter to their family doctor to go for screening. And also, I mean, the other question is implication for family planning. If someone is diagnosed with a condition, what's the chance for them to have a child with that condition, you know, so on and so forth. And then we always create a plan for next steps. But I often find that, you know, the genetic counseling piece, it comes with life events. So, you know, we have a diagnosis, you know, there's genetic counseling around that. Maybe 5 years later, they want to have children, genetic counseling can happen again. So it doesn't always happen right after the results come in. It kind of happens over time. So definitely need for it when that person is looking for that information. And actually that summarizes my part here.
Excellent. Thanks, Lauren.
No problem.
Questions for Lauren from the audience? You can post them onto the question and answer. I'll start. I'm curious about your thought. You mentioned myotonic dystrophy, which I find to be one of the more challenging conditions due to the some of the cognitive effects that it can have on the mothers of affected children. And maybe this is a more general question about how you approach genetic counseling when there may be some cognitive challenges to understanding results and their potential implications. And at what steps do you try to mitigate for that?
Yeah, I would say that's where the family letter actually comes in the most useful, actually, is actually with myotonic dystrophy. That's the situation where I will use it the most. But at least it definitely can be a challenge for sure. At least in our clinic, if there's a child involved, we'll usually do a follow-up appointment every 6 months. So sometimes, you know, the mother might realize, okay, I really want to bring somebody to the next appointment to kind of help us understand. So she'll bring somebody else, or at least we can kind of revisit every time, you know, okay, do you have any more questions? Were you able to talk to your mom and dad about this? Did they have questions? So we do kind of have those sort of little follow-ups to see if they've been able to talk to family members and if there is understanding.
Thanks. So we do have a question. It says, can families change their minds about secondary findings, or will the lab actually not report them at all if the family is opted out?
Yeah, if the family is opted out, the lab will not report secondary findings. I will generally tell families that they have probably, I'd say, you have about a week to change your mind. What is sort of nice actually with, at least in Ontario, is that we have to get approval for whole exome sequencing from our Ministry of Health. So there is going to be a period of time between when this test is sort of introduced to the family and we talk about the secondary findings. They go home, they think about it, and then I call them, 2 or 3 weeks later and say, okay, the test is approved. And then at that time, I have had 1 or 2 cases where they say, oh, by the way, I have changed my mind.
Great, thanks. It's a question from Dr. Greenberg. If you find can you read it? I don't know. I'll read it out just for everybody. If you find an incidental pathologic variant in an exome done on a 2-month-old for something like BRCA1 in it, which has more adult onset implications, you don't have to explain that the implications not only for the child down the road, but also offer testing to the parents to see from whom the child inherited the variant, and the person may be eligible for testing and screening also. Yeah,
no, definitely, and that so I guess in the conversation I had today, there, the parents are very focused on the child, so we didn't really quite get to the, implications for other family members, but that's definitely something that we talk about. Talking about, okay, if this is found in this child, it's usually not just for them, it's for the whole family. So it's going to have an implication for one of the parents. And usually at least with the lab we use, there's sort of a 2-step process. So the first question is, do the parents want to know for the 2-month-old? And they'll say yes or no. If they say yes, then the question then goes, okay, do now you parents want to be checked for that variant as well? So when we get the results back, it'll say, okay, it's found in child and, this parent, if the parents want that. And then we follow up on that as needed.
Great. And another question is, how is it decided which genes go on the secondary findings list? And how often is it updated?
So I think it was last updated in 2017. And when they did that update, they added a couple of genes and they took off a couple of genes. There is a huge group of people who are in charge of making those decisions. And the decisions, my understanding is that it's really based on how effective the screening management is for that condition. So, for using BRCA1 and BRCA2 as an example, knowing that if you are found to be at increased risk for breast or ovarian cancer because you have a genetic change in one of those genes, you can do things like prophylactic mastectomy, removing the ovaries. All those things greatly reduce the chance of cancer. For some other conditions, there isn't really great screening, so there might not be a huge impact on management if you were found to have a increased risk due to that gene, in which case that probably would not be included on the list.
Great. Excellent. I think we will move on then. If you have further questions for Lauren, please, you can add them to the question and answer, and either she can address them at other points or else type in answers as response. So Lauren, thank you for an outstanding presentation on a very important topic. All right, and I'm going to introduce the next speaker now. So it's Kim Ambergy, who's a genetic counselor at the Hospital for Sick Children. And I think with Lauren reflects the really amazing breadth of genetic counseling expertise and talent we have in Ontario, two of the real world experts in the genetic counseling of neuromuscular disorders. I've had the personal privilege of working with Kim now for more than 10 years in her role as genetic counselor for neuromuscular disorders, and I've come to appreciate her vast expertise related to diagnostics as well as counseling for families and patients. And she's going to talk today about some of the genetic testing platforms that are now available and a bit on the current sort of standards of care for genetic testing. So Kim?
Great, thanks so much. Can everyone hear me okay?
Yes, great.
Okay, and so I will get started. Let me next slide. There we go. All right, so thank you so much, Jen, for the great introduction. So I won't have to spend much time there, but I'm going to be talking about the genetic testing platforms and touching a bit on results interpretation. I do not have any disclosures or conflicts of interest to report. And I'm going to be walking you through all the different genetic testing options. I've got a lot to get through, so I'm going to talk pretty fast. So please feel free to send in questions if I go over something a bit too briefly. And then I'm also going to talk a little bit about results interpretation after you've selected your test and get the results back and how to interpret those a bit better. So first I'm going to start off with the cytogenetic tests, beginning with karyotype. And this is one that's not used quite as often anymore, but is really more for large-scale chromosomal changes and looking for structural rearrangements and marker chromosomes, and is really appropriate for patients where there's a suggestion of a chromosomal syndrome, such as one of the trisomies or Turner syndrome or things like that, multiple congenital anomalies, and a history of recurrent miscarriages and infertility. And it's important that this is more of a large scale test, so we're not looking for small deletions and duplications as part of this. Next is chromosomal microarray, which is kind of where karyotype leaves off and can now detect much smaller changes. And this is really giving you information on dosage of specific parts of chromosomes. And it's really meant for a very similar population, so patients with multiple congenital anomalies, those with developmental delay, syndromic autism, and seizure disorders. The limitations of the test is that it is not able to pick up balanced chromosomal rearrangements or specific single gene disorders where there are small changes in single nucleotides. And there is the possibility, because it is a pretty broad screen of the chromosomes, that it can identify multiple variants of uncertain significance, as many of you have probably seen before, and may uncover some incidental findings. So there may be things uncovered with the microarray that you may not be expecting and may not be relevant to the patient's current phenotype. So something to consider when ordering the test. And then the last cytogenetic study is FISH. So fluorescence in situ hybridization, and this is a much more targeted test than the previous two. And really this is kind of helping to better understand some of the structural rearrangements and copy number variants and identify the origin of marker chromosomes. And the most often use of this is follow-up, usually parental testing from chromosomal microarray to identify the inheritance pattern of the variant that may be found by CMA, and also to look for specific microdeletion or duplication syndromes such as 22q deletion syndrome. And because this is a very targeted test, it's really only answering a very specific question. Is this specific change that they developed the probes for present or not present, and does not provide any additional information about chromosomal structure or other changes. Next, we're going to talk about the molecular tests, and I'm going to go through each of those as well and kind of start off with some of the more targeted tests and then go out to whole exome and whole genome sequencing. So starting with single gene sequencing, this is typically done through Sanger sequencing or next generation sequencing. And really we're looking for single nucleotide changes. So things like single base pair substitutions, small insertions and deletions, where we're suspecting a single gene disorder. So for example, if there's a high suspicion for Rett syndrome in a patient, we could just send MECP2 testing. And the main limitation of this test is it does not detect deep intronic mutations or large deletions and duplications, unless on some next generation sequencing tests, we are able to get a bit of information on that as well. So talking about single gene deletion and duplication analysis, this is typically done through MLPA or targeted array. And we're looking for kind of small deletions or duplications or even whole gene deletions or duplications. And the context where this is typically used is when sequencing has been done, but no deletion duplication analysis has been performed. And so that can be a further test for that specific gene. Or if there's a high suspicion of a recessive disorder and only one variant has been identified so far and you want to look for a second one. Again, there is a limitation to this test in that it does not detect single nucleotide substitutions, insertions, or deletions. The next test is a targeted mutation analysis, and this is typically done as screening in other family members. So if a genetic confirmation of a condition has been found in a proband, we're able to offer very targeted testing for additional family members. And this is a very targeted test to look for a specific mutation that's been previously identified. The other times that this may be used is in conditions where there are recurrent mutations, if there's certain hotspots in a gene or things like that, where we can screen quite easily for recurrent mutations. Again, because it is a very targeted test, it's only going to provide information about the specific variant or variants that are being assessed and not any additional information beyond that. The next type of technology is repeat analysis. This is typically done through Southern blot and is really looking for repeat disorders. So those that are caused by repeat expansions or contractions. So some examples would be Fragile X, Friedreich ataxia, Huntington disease, FSHD. These are the types of tests that will be screened by this type of analysis and not picked up by other genetic tests. And because it is a very specific test, it's not going to give you information, any other information other than the repeat number. And often these tests, because of the technology, it does often require a fresh blood sample. So something to keep in mind when ordering the test. Next are gene panels, and there's kind of two different ways to approach gene panels. There's kind of a targeted capture approach where there's a small number of genes that are on the panel, and there's pretty good coverage of each of those genes, and it's only going to be looking at those specific genes, versus there's also a whole exome approach where a whole exome is run, but only analysis of the specific genes of interest will be analyzed. And there are certainly pluses and minuses to doing each of those methods. This type of testing is going to pick up single nucleotide changes, as well as larger deletions and duplications for next generation sequencing panels. And this is typically ordered in patients where there's a condition with significant genetic heterogeneity, or there's kind of a small number of conditions that are being considered, not a very broad differential. With many genetic tests, with a gene panel, you are limiting the number of genes, but there is more than one. So there's the possibility of getting multiple variants of uncertain significance, and some of these may be in genes that may not be as relevant to your patient's phenotype. The testing does not detect large chromosomal rearrangements or deep intronic variants. And then last, I'm going to go through whole exome and whole genome sequencing. So Lauren kind of touched on some of the things to be considering from the counseling standpoint, and then I'll go through kind of a little bit of the technical information and comparing the two different technologies. So the exome is really only covering about 1% to 2% of our entire genetic material, but the majority of genetic diseases and pathogenic variants can be found in the exome. With whole exome sequencing, we are able to detect single nucleotide changes, as well as some of the larger deletions and duplications as well. And it's appropriate for patients where there is a large differential diagnosis, where there's multiple conditions being considered. And it's very important before proceeding to this test to consider ruling out some of the common single gene disorders, and especially those conditions that will not be picked up. So for example, if there's a suspicion for FSHD, whole exome sequencing would not be the appropriate test to do. You'd want to do the repeat analysis prior to pursuing whole exome sequencing if that's something you're considering in your patient. And as Lauren spoke about, there is the possibility of identifying multiple variants of uncertain significance because this is such a broad screen, and also the option to find out about those secondary findings. One limitation of this test is that it does not detect large chromosomal rearrangements or deep intronic variants. And this is where whole genome sequencing really comes in and can fill that gap. In addition to being able to detect everything that is detected by whole exome sequencing, it adds on detection of deep intronic variants as well. And again, it's appropriate for the same group of patients where there's a large differential being considered, and common single gene disorders have already been ruled out. Again, the same limitations in that it can you can identify multiple variants of uncertain significance, as well as the option to identify secondary findings. And the one kind of major thing around whole genome sequencing is we are learning quite a bit about the different non-coding and regulatory elements, and we're still learning how to interpret those. So there's still a lot of information with whole genome sequencing that we're still learning how to understand. And this slide is meant to be kind of a summary of each of the technologies that I briefly touched on to help you give a sense as you're creating your differential and your plan for testing, to consider the different types of tests and what they can show you. So really, as you're creating your differential, you really want to have a good understanding of the molecular mechanism of each of those conditions to identify the correct test that will be appropriate for your patient, or a combination of tests. You want to find a strategy that's going to be efficient and cost effective if possible. You want to consider the prevalence of the conditions that you're considering. If there are certain common conditions, even if they aren't a great fit, but may not be picked up by other technologies, you may want to consider screening for those. You want to consider how well the conditions fit with your patient's phenotype and the likelihood of getting a positive diagnosis. And you also want to consider the information that your patient wants to know. So Lauren kind of went into this, and do your patients want to find out kind of this broad information? Do they want those secondary findings and other information that may not be relevant at the time being for the patient? And I think I just saw is there a question that came up?
Yeah, there's a question, why can't whole genome sequencing identify trinucleotide repeats?
So it's a different type of mutation, and so you really have to do a targeted repeat analysis to be able to pick up those repeat disorders. So it's a separate test that you have to order.
I can just add a little bit onto that if you don't mind, Kim.
Sure.
So part of the issue is that with genome sequencing, the read length is only usually somewhere around 30 nucleotides. And so you can imagine if your repeat is larger than 30 nucleotides, it's very hard for the informatics to file the sequence to show the length of repeat. That being said, Ryan Yuen, who is a scientist at the Research Institute at SickKids, has just published a paper showing how you can use the short read genome sequencing to identify trinucleotide repeats. So I think this is an evolving area, and I think the hope is that someday exome or genomes will be suitable for identifying repeat expansions. So I encourage everyone to, I can see if I can find the link to that paper and post it in. So I think it's in the future, but not yet clinically validated. So sorry, Kim. Do you want to answer this next question, or do you want to go on to?
Sure, I can just address it really quickly. So it's kind of asking about the cost of effectiveness of single gene tests versus panels versus exome sequencing, and it's really based on the patient, the information that they want to gain from the testing. If doing a broad test like whole exome sequencing is going to provide too much information for the patient, more targeted testing may be appropriate, and also considering the costs. So it's really dependent on different labs and consideration of the number of genes on those panels. So at least in Ontario, the ministry will approve whole exome sequencing if you've had a panel less than 100 genes. They feel that kind of going above that, the efficacy of exome is going to be a bit less. So that's something to consider when choosing the test. And so it's really on a case-by-case basis, figuring out what's going to be cost-effective for your patient and the information that they want to know. But in general, the only single gene test that we're typically sending prior to going on to larger panels or whole exome sequencing is where they're more kind of common conditions that we can screen for pretty easily and at not a huge cost.
Kim, are you able to just, I know you've looked into this, so just mention sort of currently say you were doing a 40 gene or so neuromuscular gene panel versus an exome in terms of relative cost at the moment?
Yeah, so panels are typically running, I think the cheapest right now is usually about $750 US dollars, and usually I think that's the cheapest, and it's usually around there to around $1,000 versus whole exome sequencing is usually around the $3,000 to $3,500 US dollar range. So it is something to consider in creating your testing strategy and choosing the likelihood of which one's going to give you a positive result and balancing that with the information that the patient wants to know and the cost effectiveness. All right. So now I want to test everyone's knowledge so we can start seeing how much you've learned, hopefully, from the quick information that I ran through. So we've got a couple of case scenarios to go through, and I'm going to have everyone kind of, I'm going to poll the audience to see what your thoughts are. And we're going to go through each of these scenarios, and I want you to vote for the one that you would choose as kind of your first line test for this patient given the scenario. So the first scenario would be a 10-year-old boy with distal weakness and atrophy, has cavus, hammer toes, abnormal sensory exam, and EMG consistent with demyelinating neuropathy. So of those 4 choices, what would be your first line test that you would offer to that patient? Oops. So hopefully I'll give you a few minutes to go through that, and we should be able to see the results. Aha. So it looks like the highest number was for a CMT panel. So while I agree that obviously is very suggestive of CMT, in this particular case, especially with a demyelinating neuropathy, the most common cause is going to be a PMP22 duplication. So I would actually recommend starting with that and then going to a CMT panel. All right, and Hamir, if you can bring up the next scenario. All right, so now we have a 5-year-old girl with dysmorphic features and global delay. So again, what would be the first line test or group of tests that you would offer to your patient? All right. And so 79% of you said CMA, Fragile X, and consider Rett syndrome, which is the correct answer. So that's going to be the first set of tests that you'll want to consider. And then typically what we would consider after that would be going to whole exome sequencing. And then we'll quickly do the last scenario. Hopefully this one will be pretty straightforward. 3-year-old boy with global delay and elevated CK. Again, of the 4 choices, what would be the first test that you would offer? All right, and 94% of you got it right. We'd go straight to DMD deletion duplication analysis followed by DMD sequencing. So this is an opportunity where you can go straight to single gene testing. Great, all right. Let me go back to my slides. Thank you for your participation. And now I'm quickly just gonna go through, so after you have decided on the test to be ordered, now when you get the results back, how do you interpret these and what are the things you need to understand? Again, I'm going to start off on the cytogenetic side. And just to remind you from the chromosome, I want to go through a quick anatomy of the chromosome. So we have the short arm, the P arm or petite arm, followed by the long arm, which is the Q arm. In the center, we have the centromere, and the edges, we have the telomeres. And this is the nomenclature that's going to be used in many of the cytogenetic reports. And I'm not going to go through each of these, but just to give you a sense, these are things you can refer back to when you've got your report in front of you to help you better understand what the different symbols mean so that you can understand what is being reported in your cytogenetics report. And then I encourage you to look through the interpretation section so that typically in there, they've got a lot of the information that you're going to need, the different genes that are in that region. For example, in a chromosomal microarray, if you've got a deletion, which OMIM and REF-seq genes are included in that region and may be relevant to your patient or not, and if there are any previously reported cases. On the molecular nomenclature, you're always going to get back information about the gene that where a variant has been identified and where it is in the DNA as well as in the protein. So for this example, this is the BRAF gene, and that first letter is C, telling you it's in the coding DNA. And at position 1799, there's a substitution of a T to an A. And in the protein, that P dot is telling you it's in the protein. They're at codon 600, there's a valine, which is changed to a glutamic acid. So that way you have a sense, this is a missense mutation, and have a sense of what the nomenclature is. Again, I have the nomenclature for you to refer back to. So those symbols in the beginning are really telling you the reference sequence that they're referring to, so you know whether you're dealing with the coding DNA, the genomic DNA, is it mitochondrial or RNA or protein, and then the different symbols that will be used as part of that nomenclature. And also to remember the different types of mutations, whether it's a missense mutation, so there's a substitution at one nucleotide, a nonsense mutation where the instructions stop too soon, or insertions or deletions. It's important to think about the different mutation types when you get your results back. And then you're also given information on the pathogenicity of the variant. And to really standardize this, the ACMG has come up with some guidelines to identify the variant and how likely they feel that this is a pathogenic change or something benign. And to show you here, these are the different guidelines that are used so that it's standard between different labs and how they will be reported. The other information that you'll typically see on your molecular reports are going to be whether or not the variant has been previously identified in the medical literature and give you the citations for that, as well as the allele frequencies in the general population and prediction programs to give you a sense of whether or not the variant affects protein function or structure. And I just wanted to touch briefly on the different variant databases that are used to help come up with those reports. And these are the publicly available databases. So the first is ClinVar, and this is going to give you information on your variant and the evidence that is supportive of the pathogenicity of that variant and how it's being interpreted in relation to a condition. And the information in this database is gathered from the medical literature and entered by genetic testing laboratories and research studies, as well as other sources. And lastly, for the allele frequencies, the databases that are typically used are Exact and Nomad. And these are databases that are generated from very large-scale sequencing projects, mainly from healthy individuals. Exact has the exome data, whereas Nomad has the exome and genome data. And this is where you can get the information on allele frequencies and estimates on the tolerance of mutations in that gene. And I think that's it from me.
Excellent. Great talk, Kim. Thanks for such a thorough and easily understood overview of testing technologies. Do we have any quick questions for Kim? I think we've got a few minutes for a couple questions. I know some were already asked. So if people have questions as we move forward, please enter them into the question and answer, and we can certainly, if time permits at the end, come back to them. So why don't we move forward then? Thanks, Kim, for a great talk. Next I'll introduce Hernan Gonarowski, who's a staff clinician at the Hospital for Sick Children and a neuromuscular specialist and expert, and I'm very proud to have him as a colleague at Sick Kids. He's really been instrumental in leading our efforts to understand the potential role of different diagnostic modalities in the genomics era, and that's what he's going to be focusing his discussion on today.
Thank you, Jim. Everybody can hear me well?
Yep.
Yes? Okay, great. So as Jim was saying, I'm going to discuss non-genetic testing in the genomic era. So I don't know how we are doing in time, but I'll try to do it as fast as possible. If you have any questions, just let me know. I don't have any conflict of interest with this specific talk. So I just want to introduce, I usually present this case because I think it's an interesting case that represents basically how genomic testing actually has helped on the diagnosis. This is a patient that actually I met while I was working back in Argentina. He was, at that time, was actually 48 years old. With the previous history of hypotonia and generalized hypertrophy since infancy with a limb girdle muscle distribution. As you can see in the pictures, there was a diminished muscle bulk throughout, mild facial weakness, no ptosis, no contractures. The EMG that he presented, like he came to the consult and like he had several studies in the past, was a myopathic EMG with a CK that was around 430, no cardiomyopathy, no ventilatory problems, and with no cognitive involvement. He actually got 2 muscle biopsies, one when he was a kid and then the other one as a teenager. Both of them actually reported like a bacular myopathy, as you can see in the pictures. So when the genetic people, or eventually the staff who actually was being following him, requested genetic testing for Pompe, Danon, and X-linked myopathy with excessive autophagy, and everything was actually negative. So what to do next? So basically when he saw me, I mean, exome was actually already available, and that's when we actually do whole exome sequencing analysis on this case, because we were thinking about actually a myopathy. And he found a report compound heterozygous mutation in the gene GFPT1 that's known as produce a congenital myasthenic syndrome with bias with tubular aggregation in the muscle biopsy. So we reviewed the case on the study that he actually had, and we did a repetitive nerve stimulation, and there was actually a decrement, as you can see in the picture. And when we re-reviewed the muscle biopsy and we were looking for the end-plane junctions, we see that there was abnormalities on the end-plane junctions. As you can see, I don't know if you're seeing my arrow, but you can see on the right end the sarcomeres, and let me just take this out. And you can see with the arrows there, the abnormalities on the postsynaptic end-plane junction. So with this case, I just want to give a good example that devil is in the details. And although exons and the genetic testing actually has helped us a lot on the diagnosis, sometimes you will actually found, and as Jim is going to explain later, like variant of unknown significance, or you may have no diagnosis at all, even with whole exome sequencing. And I think the increment of the diagnosis or the diagnostic yield of any genetic testing will actually come with a really good details on the patients, and trying to characterize really well each patient. That's why having a non-genetic testing will actually help you in that sense. So the first thing, but I'm not going to go into much details, is a non-genetic testing, which is actually an approach to neuromuscular disorders, like having a good clinical history and physical examination. Because as you can see here, it's not the same the patient on the left and the right on the clinical examination. The patient on the left, as you can see, has a muscle atrophy compared with the right that it seems to be like hypertrophic. On the walking itself, on the patient on the left, there is a limb girdle pattern distribution, while the patient on the right has a more like foot drop distribution. So the patient on the right, you will say, okay, this looks more like a distal myopathy or eventually neuropathy, and the patient on the left, it will fit more in a limb girdle muscle dystrophy or limb girdle type of a neuromuscular disorder. So when you're actually characterizing this is a typical classification of a muscle weakness distribution, at least for the myopathies. Okay, but this is not enough. We know now that each of them may have a further classification when you are actually approaching to a diagnosis. So again, if you look at the patient on the left, oh, sorry, and just take out the sound. There we go. Sorry about the sound. So if you see the patient on the left and the right, I mean, both of them have the distal involvement, but the patient on the right actually has atrophy of the gastrocnemius, and the patient has difficulty standing on the tiptoes, compared with the patient on the left that actually has weakness on walking on their heels. So both of them actually have the distal myopathy, but there are different distribution of on the muscle component or muscle compartments. So when we actually do a muscle MRI in these patients, you can see in the patient on the left, there is a severe atrophy, and this is like whitish color. So this hyperintensity on the MRI, on the tibialis, on the anterior component of the calf, and in the patient on the right, there is actually involvement of the gastrocnemius and a little asymmetry between the components. The patient on the left actually has a myofibrillar myopathy due to desminopathy, and the right is a Mayoshi myopathy. So as you can see in distal myopathies, and this is just an example, there's a different forms or different components of muscle involvement that actually can help you in your differential diagnosis. So the distal myopathy that you usually start then depends on the age of onset and also the muscle biopsy, and depending also on the compartment that is actually going to be involved, you actually can classify and actually distinguish even more your diagnosis, or eventually have a better phenotype of the patients and once you actually go to a genetic panel. So this is what we're going to talk about. This is the complementary studies. I mean, CPK, EMG, MRI, images, and genetics. Of course, we are not going to talk about that because it has been already discussed. So CK, really briefly, I mean, CK levels is not only to actually say, okay, if it's elevated, it's going to be like a dystrophy. Within the CK levels itself, you need to understand that some of the disorders will have a specific really high CK. For example, in the case of the Duchenne, sarcolemcan, sanoctamin, dysferlin, they will be tend to be like more in the higher end of the CK, while, for example, congenital myopathies, they will tend to be more like in the normal side, or MDC1A will be more like in between 1,000 to 2,000. It's important also to have at least 2 CPK levels, because it could be that the patient presented with a rhabdomyolysis, and you want to know that eventually that CPK will actually normalize. Because in the case of myocardial, for example, the CK will tend to be actually slightly abnormal, and in the case of CPT2, it tends to be like normal. So it will be important to actually do it at least twice. In the case of newborns, the CK is actually high. And actually, we get quite a few consults in NICU because of the high CK in a newborn. But we know that the patients, like newborn patients, vaginal delivery or C-section, they can have a high CK. And over the days, it's going to normalize. So eventually, you will need to repeat the CK in around 6 to 7 days just to see if that is the normalization. And if it's especially really high, eventually, you will need to repeat it down the road to see if it's actually completely normal, or it will stay like slightly elevated. So it's important that we actually do, I mean, in terms of the CK, you should do it before eventually the other study, which is EMG. I mean, it can get elevated, especially if you're doing several muscles, but it's not like super highly elevated. Usually it's recommended to do a CK level before actually doing EMG. With electrophysiological studies, we will include EMG, neuroconduction studies, repetitive neurostimulation, and single fiber. So what's the role of these electrophysiological studies in the genomic area? I mean, the things that you're going to check, for example, in EMG is like, what's going on at rest, slight contraction, maximal contraction, and depending on that, you will actually can classify it on does this patient looks like more like a myopathy, does this patient has a neuropathy or motor neuron disorder, or eventually neuromuscular junction disorder. But not only that, you actually, for example, in the case of myopathy, if you're doing a needle exam, you may have actually, it might guide you more in terms of the diagnosis, because you can have myopathies with neuropathies, like LMNA, for example, myopathies without spontaneous activities, or myopathies with spontaneous activity, with presence of myotonia, myopathies with typical having the complex repetitive discharges, myotonia without actually myopathic pattern, or eventually patient would present a weakness with a normal electrophysiological study. So that would make you think more in metabolic myopathies. So whenever you are actually looking for EMG, I don't think it's going to be enough to say, okay, this is a myopathy. It will have a better characterization, and it will guide you into your diagnosis, and it will guide your genetic testing. But it's important to know that at least, like if we're looking for myopathies in particular in the younger population, less than 2 years of age, the role of the EMG is actually not quite clear, unless you're actually looking for neuropathies or eventually motor neuron disorders that are actually quite good, like in the green box. EMG was actually positive for nerve neuropathy disorders. For muscular disorders, actually the EMG was like half and half. In terms of a false positive, false negative rate. Why? Because basically the technical difficulties. I mean, in newborns, the muscle fibers are really small. You can confound the muscle unit potentials with a more like a myopathic pattern. So if you're thinking about a myopathy in the younger population, especially in the newborns, I will say, okay, just go for genetic testing, eventually muscle biopsy. If you're not really sure where the problem is, eventually you should actually do EMG neuroconduction study to see if there's a neuropathy component or a motor neuron component. So we were just mentioning muscle biopsies. So the muscle biopsy is why to do it. Well, it's cheap, it's fast, and actually can help you with your diagnosis. But the question is, like, when should we do it? Before genomic era, I mean, this is the gold standard. I mean, you will do it, and then you will guide the diagnosis. Currently, actually, the muscle biopsy has actually taken second place compared with the genetic studies, especially because, I mean, it's invasive. So if you show this to a kid, you say, okay, we're going to do a muscle biopsy. I mean, the kid will be really scared. but although it has taken second place in most of the times, it depends on the centers, of course. It still have a role. I mean, if you have a patient with a NICU with a newborn screening, NICU newborn, depends on the center again. If it's going to take weeks or months to actually get a genetic result back, you may want to do a muscle biopsy if you're suspecting a myopathy. In the case, just to orientate your diagnosis, and maybe there's a clear findings there that will help you in deciding what to do next. So in NICU, I mean, it might be prioritized the muscle biopsy, and it will depend on the center, and it depends where you are actually working. So you know that, I mean, muscle biopsies, I mean, there are more than all these two, but this is like the main categories from the genetic point of view. Of course, you have metabolic myopathies, mitochondrial disorders, okay? But you can actually distinguish dystrophies with the congenital myopathies basically on the muscle biopsies. I'm not going to go into details into this. But the problem is, like, even with the muscle biopsies, you may have an overlapping findings in the muscle biopsy. For example, in genes like ACTA1, you may have a congenital fiber type disproportion. You can have an MLA myopathy. Titan is a good example that you may have central core, central nuclear myopathies, congenital fiber type disproportion. So although it might orientate your diagnosis, you still have this overlapping on the findings on the muscle biopsy. So the other thing is which muscle you are going to actually do the biopsy, and if you may do just a physical examination. If the patient, if the muscle is weak enough, you say, okay, we'll just go there. But you need to be careful, because if you do a muscle biopsy in a really atrophic muscle, the only thing you're going to see is basically fat replacement, and that will lead us to the second step, which basically is just a muscle biopsy guide by imaging. So in this study for patients with inflammatory myopathy, the muscle biopsy was normal or showed non-specific findings in approximately 10 to 20% of the patients. But when they were actually guiding it through with imaging, MRI, the false negative rate dropped from 0.23 to 0.06 with a combined procedure. So it looks like muscle biopsy looks really good with actually MRI. And we know that not all the muscles actually in genetic disorders will actually be the same. I mean, we did the studies on mice in the MTM, for example. Not all the muscles were actually quite affected, and the findings on the muscle biopsies were more predominant in specific muscles, and some other muscles were completely normal. So why to use eventually MRI? Well, for disease characterization, will help you for muscle pattern. It will have some of the disorders have a really good genotype-phenotype correlation. You can have algorithm in terms of the diagnosis. Outcome measures. I mean, in the terms of the clinical trials, some of the clinical trials or some patients will be discouraged if the clinical trials will actually need to have 2 or 3 biopsies. But MRI actually has been taking a more important role in terms of the outcomes and follow up on these patients. So when you're thinking about imaging, I mean, you can use MRI versus CT. So what's the difference between one or the other? I'm not going to talk about ultrasound. I will just talk about these two. Distribution of lesion basically is the same, MRI and CT. This is a CT from a thigh, and the one in the bottom is a MRI. And you can see the sartorius and gracilis, basically where the arrow is, and the semitendinosus muscles are affected with hyperintensity and hypodense in the CT. Fat infiltration basically is the same. Presence of edema is actually much more like better the MRI. On the CT, on the side, this is a juvenile dermatomyositis patient. On the MRI is a T1, but when we actually do a fat SAT suppress, we can see there is a hyperintensity on the MRI, which is quite characteristic for juvenile dermatomyositis in this case. But actually on this the CT we couldn't see anything. Diagnosis of fibrosis, actually the fibrosis is, although you can actually see it on the CT, is better characterized on the MRI. This is a COL6 related myopathy. And actually this finding, the picture of on the MRI finding is quite characteristic for COL6 related myopathy. You can also do muscle metabolic investigations, especially with a phosphorus spectrum. And because of timing, I will not go into describe a lot, but about this. But I think the things that you actually can study from the metabolic or functional studies are really, really interesting. And of course, I mean, X-ray. I mean, in pediatrics, you tend not to use CT, so we'll go for MRI and try to avoid X-ray dose. So how to do, how to look at the study. So a T1 will help you. The muscle tissue will look like a brownish color. Connective tissue is more like black, and a fatty component, which is basically fat replacement, will look like hyperintense and white. So the sequence we tend to use is T1, non-fat sat T2, and fat sat T2. So basically, fat sat T2 is like will actually suppress the fat. So if you have fat in T1 and T2, you have this the semitendinosus muscle is hyperintense, and in the fat sat is actually hypointense. And when we see edema, the T1 and T2 is also hyperintense. However, in T2 fat sat is hyperintense as well. So you actually can distinguish between one and the other. And why you want to distinguish? Well, T1 will use to evaluate fat replacement, pattern recognition, and T2 fat sat for presence of edema that could be related to acute injury, inflammatory myopathies, or acute denervation. You can do a qualitative actually report. I mean, this is a modified from Mercury, different stages of fat replacement. You need to have a muscle atlas. That's important for you to actually have always, okay? And there are some super basic rules. It doesn't actually really apply in terms of MRI and dystrophy. MRI induced for dystrophy and congenital myopathy, just to distinguish. So muscle edema usually seen in the dystrophies, of course, also in inflammatory myopathies. So that tends to be more related to dystrophies that you will not see in congenital myopathies. Early involvement of the muscles like gracilis and sartorius, it tends to be more related to congenital myopathies. Not always, but tends to be more related to it. And involvement of the masticatory muscles tends to be more related to congenital myopathy. Of course, for example, in disorders like myotonic dystrophy, you will have more like involvement of the masticatory muscles, and that's quite obvious usually also like from the clinical point of view. So the question is like, when should we do MRIs? I mean, and how to read it? I mean, the MRIs, you will not use it right away. If you have a really good characterization of the patient, that's when you don't tend to use it. When you are not sure, at least that's in my practice, if you're not sure what the phenotype of the patient, I tend to use the MRI not only for a better characterization on the phenotype, but also to eventually guide the basal biopsy if I need it. So when you're actually reading the muscle MRIs, you need to analyze step by step, like systematically. You should have a scoring or regional analysis. If you have a selective involvement, like a positive pattern, which muscles are affected, or eventually if it's a diffuse involvement, you should have a negative pattern, so which muscles are actually preserved. Always use your atlas. So in this case, as you can see in the MRI, the hyperintensity is all basically on the posterior compartment on the thighs, involving the abductor longus, abductor magnus, semimembranosus, semitendinosus, and bicep femoralis. And you can actually see the hypertrophy of the sartorius and the gracilis muscle. In a patient like this that actually has in this case, I didn't tell you the clinical story, which is more like a lingual muscle distribution with a CK between 5,000 and 6,000. With this MRI pattern, you will think about those two specific disorders at least, which is actually one of the two most frequent ones, which is the calpain and FKRP lingual muscle related. So I didn't put the cuff basically, but the cuff actually will distinguish the involvement between FKRP and calpain. So the MRI will help you and in terms of in the patterns and maybe guiding your diagnosis or eventually selecting the panels. So in summary, a good characterization of the phenotype of the patient will increase your diagnostic yield for genetic studies, and MRI and muscle biopsy currently are not the first line on the diagnosis algorithm, at least not here, but should be considered in patients with no clear phenotype or without clear genetic results. For example, interpreting variant of unknown significance. Thank you.
Excellent. Great talk, Hernan. Do we have any questions? All right, I think for the sake of time, we're going to move on because we've got about 15 minutes left and I want to make sure everybody is able to get to their dinner, etc. And I think that leaves me now as the final speaker. Let me, share screen. Okay, I think, is there none? Do you have to end your screen sharing?
Let me see. There we go.
All right. Excellent. Perfect. Well, many of the concepts I'm going to talk about have already been covered, which is great. So I'm going to be presenting about variants of unknown significance. In case you don't know who I am, I'm Jim Dowling. I'm a clinician scientist at the Hospital for Sick Children. So just in terms of disclosures, I have no relevant disclosures to today's talk, though we'll be talking about RNA sequencing, which we have a team grant for developing as a clinical test. So I wanted to start really picking up from where Kim and Hernan have left off, which is, so you've done your genetic testing, you've used the standard of care that Kim talked about, and you're not in the 50% that are solved with our current methodology. So if you look at all the data right now about multi-gene panels or whole exome sequencing for neuromuscular diseases, the solve rate is right around 50%. So the question is what happens or what to consider for the unsolved 50%. And I would consider the results in this category usually falling into 3 bins. One is what I'm going to really focus on today, which is having a variant of unknown significance in a known neuromuscular disease gene. Another, and this is really only applicable to whole exome sequencing, there's a variant of unknown significance in a candidate gene, which may or may not fit as a new cause of an individual's condition. And then the third possibility that there's no changes of potential disease relevance, which I'll touch on just very briefly at the end if I have time. So just to give you a real world flavor about this 50% diagnostic solve rate, this is something that Kim compiled a year or 2 ago from our clinic experience covering about 2 years of patients seen between myself, Hernan, and Dr. Grace Yoon. And if you focus on the bottom number there, you can see that if we took all comers who came to our neuromuscular clinic who had genetic diagnostic testing, we were solving about 50%, 56%, where we had a definitive genetic diagnosis after doing testing. So, and this breaks down the different categories, but this is just to show that these theoretical numbers that have come out of some of the cohort studies is something that we're seeing in practicality in our clinic. But again, the focus of this is going to be on those individuals where there is not a solved genetic basis from their genetic testing, but rather a variant of unknown significance. And this is quite an important problem in neuromuscular diseases, and in particular because some of the genes where mutations are among the most common cause of neuromuscular disease, such as RYR1 and Titin, also happen to be some of the genes where there is the most potential for variants of unknown significance. I was reading a paper earlier today talking about variants and listed Titin as the second most variable gene in the genome. So it's no surprise that one often gets variants of unknown significance in that gene, and the question is what to do about them. And this is, I think, something that we all struggle with, is how to try to classify as to whether these variants are actual cause of disease or rather something that's not the primary cause, and therefore other causes need to be looked for. So Kim presented this already, so I'm not going to go into it in detail, which is the American College of Medical Genetics variant scoring system. So again, we're dealing with this big gray box in the middle, the variants of unknown significance. So these are variants that are not clearly disease associated, but also not clearly not disease associated, and therefore require some additional consideration in order to be better classified. So I wanted to start with an example. This is a patient that Grace and I have seen in clinic, and Kim also participated in the clinical care, and a patient that we sent a congenital myopathy panel for in 2015 because of the indication of low muscle tone and congenital onset of weakness. The panel came back with the result of no clear pathogenic sequence variants, but 2 variants of unknown significance in known neuromuscular disease-associated genes, one in Dynamin-2 and one in MYH7. So what do we do with this information? So you can see, first of all, that there is some interpretation provided by the company. This was done at, I believe, in Vitae, and they classify one as being likely benign and the other as being a variant of unknown significance. So if we step back and say more generally, what are our strategies for evaluating a variant of unknown significance? The first step often is just looking at the variant itself. I should actually say that the first step is often familial testing, as Lauren mentioned, when one has a variant, to try to classify or understand whether it's something that's inherited or de novo, and if there's more than one variant, to see if they happen to be inherited in cis or in trans. And that can often help in clarifying potential pathogenicity, because, for example, if it's a recessive condition and the individual has 2 variants, but they are both inherited from the mother, for example, and therefore on the same allele, it is very unlikely that they're the actual cause of disease. So as I mentioned, most of the companies where you do commercial testing will provide results from the prediction algorithm programs, including programs such as SIFT, Polyphen, and CAD. These programs do help in terms of clarifying a variant, but they have important limitations. And I think it's important to understand that these programs are based largely on population frequency, evolutionary conservation of the specific sequence, and predicted impact on protein. So all theoretics that can provide some insight, but in and of themselves are not sufficient to truly classify. So if something is if a variant is exceedingly rare in the population, that doesn't necessarily make it disease causing. And similarly, if it is an evolutionary conserved sequence, it still may not be important for the protein. There are new prediction programs that are being developed, and hopefully some of these newer programs, which are integrating additional functional data, may help better clarify variant pathogenicity. So for example, there was a recent publication on RYR1 variants that incorporated about 2,000 known patient variants and also the cryo-EM structure of the RYR1 protein, and integrated the two with some functional data that the group had generated, and provided a pretty robust system for looking at variants in the RYR1 gene. Perhaps the most critical element of examining variants of unknown significance is the clinical picture. And this is something that Hernan just emphasized, and trying to reflect whether a variant fits with the clinical understanding of disease could be really key in its classification. And then combining that with additional clinical testing using the modalities that Hernan just went through in excellent detail: muscle biopsy, muscle imaging, and EMG nerve conduction study. And then finally, what I'd consider more boutique testing that's often done on a research basis, and that would be functional analyses of patient-related material and or mutation-specific material. So this is just a recent paper that emphasizes the fact that the prediction programs that many of the companies use are not terribly specific. So if you focus here on the column of specificity and you look at CAD and SIFT, which are 2 of the most common scores used, they have a specificity of about 60% in terms of resolving variants strictly based on informatics criteria. So you can see that they are only so useful when one considers using them as a means of trying to understand variants. I think a pretty classic example is Titan, where a group in Australia has been working very hard to try to better understand how to classify the variants, and found that these standard prediction programs are wrong almost all the time when it comes to interpreting Titan variants. So this is just a little plug for a newer analytic tool that just came out. This is from Jocelyn Laporte and Johan Boehm in Strasbourg. They've developed what they call Mystic, which is an in silico tool that combines several known tools and also some functional analyses to try to better classify missense variants. So I found it fun to go through their website and look at some of my favorite genes and variants of interest. And so this may be, this and others are interesting, helpful tools to think about that may be better classifying these variants. But as I mentioned, I think really the anchor of trying to work through variants of unknown significance comes back to very thorough clinical phenotyping. And I think this is a good plug for all of the neurologists and allied health professionals on the call, that we're not going to lose our jobs because of sequencing. Actually, I think our ability to do accurate phenotyping has become even more important in the genomics era because of things like variants of unknown significance. This is an excellent table that Hernan produced for a book chapter that we wrote, and is further repeated in the review article listed below. It's not 2029, though that would be kind of cool. He did not do it in the future. But I think it underscores some of the fact that one is able to do quite a bit of disease subclassification based on clinical features. And just to further delve into this, these are some figures from the same paper. And it presents some of the unique features that can occur in different subtypes of neuromuscular disease. So the top panel shows several examples of facial weakness and can be very helpful in terms of variant classification because some conditions will invariably have different facial muscles being weak, whereas others will never have that is the case. So for example, the patient on the far left has Dyneman 2 related central nuclear myopathy, and ophthalmoparesis is an invariant feature of that condition. And so can be very useful in terms of classifying a variant. The right panel shows an individual with collagen 6 myopathy, and features like hypermobility of the distal joints can be something that can be very useful in terms of classifying collagen 6 variants, which can occur quite commonly in gene panels. And so I think this is quite a helpful thing to consider. So these I'm not going to belabor because Hernan already went through them, the important diagnostic tools that can be used for variant of unknown significant analyses. So just to go through a quick example, this is an individual that we saw who had a clinical presentation consistent with collagen 6 myopathy, and genetic testing showed a intronic variant of unknown significance. We classified this variant further through multiple modalities. One is muscle MRI, and the individual had a classic MRI pattern for collagen 6 myopathy. We also did RNA analysis from patient fibroblasts and were able to show that the variant caused an abnormality in the collagen 6 RNA processing. And finally, we used immunostaining on patient fibroblasts to show that collagen 6 was misdistributed, which is typical for the disease. So combining everything together, we're able to confidently reclassify a variant of unknown significance as being pathogenic and the cause of disease in this patient. I don't think I need to plug MRI anymore because Hernan did that quite thoroughly. So another example of clarifying a VUS, this is a case of a 13-year-old girl that we've been following at Sick Kids, who presented with myalgias, calf hypertrophy, toe walking, and ankle contractures, as well as an persistently elevated CPK. We did a limb girdle muscular dystrophy gene panel, which had 3 variants of unknown significance. One in the ISPD gene, which is typically a recessive gene, so we felt confident in dismissing that. The clinical phenotype did not fit with LRP4. And then there was a DMD variant of uncertain significance. And so the prospect that this was a case of a manifesting DMD carrier was entertained. This is the details provided by the company about the variant, classifying it as a variant of unknown significance. We then went on to perform a muscle biopsy and use the muscle biopsy for 2 ways. One was to do RNA analysis of the dystrophin gene. And the RNA analysis was able to detect that this was causing an insertion that led to a frame shift, and thus was a classical pathogenic variant in the DMD gene. And furthermore, based on muscle biopsy, we actually repeated the biopsy twice. We saw a dystrophic pattern with absent dystrophin expression, suggestive of a dystrophin mutation as the cause of disease. So by summating these additional diagnostic tests, we were able to move a variant of unknown significance to classify it as a pathogenic variant and succeed in diagnosing this individual with manifesting carrier status of DMD. So just a quick bit on RNA analysis and variants of unknown significance. So the collagen 6 case and this DMD case were examples where intronic mutations that altered RNA processing were the cause of disease. In both cases, we used RT-PCR analysis as a way of interrogating the RNA. And this is a suitable method that is currently clinically available in some labs, such as the Sick Kids Lab for the DMD testing. However, it's not an adequate method really for more broad analysis of RNA transcripts. And for that, we've and others have been working on doing a more broad-based technology called RNA sequencing. If you'll recall the previous webinar, there was an excellent presentation on RNA sequencing, and I think that's archived if you want to go back to hear it. But the basic idea, it's very similar to thinking about whole exome or whole genome sequencing, but instead of surveying the genomic DNA, it's surveying the RNA, the transcriptome. We've been able to show for neuromuscular disorders using a relatively large cohort of individuals that we could provide resolution of the genetic basis of the disease in up to 40% of either gene panel or whole exome negative cases. So this seems to be an excellent modality to add to the diagnostic repertoire when gene panel or exome sequencing is non-diagnostic. It's particularly good for clarifying variants that may impact RNA processing and or for identifying them if they were not first identified by the sequencing technology. And again, just a small plug for our joint team project at Sick Kids, where we hope within the next 12 months to have a clinically available test that hopefully will be available and to all neuromuscular providers across Canada to help with clarification of gene mutations. And this is just a figure from our manuscript showing our RNA sequencing pipeline, which I will move past for the interest of time. So just to conclude, what happens if you've gone all these things I've talked about and you still have not clarified your variant of unknown significance? So there are some research-based functional testing that can be considered, particularly if the function of the gene is well enumerated. So I give the example of RYR1, which is a calcium channel found in the terminal sarcoplasmic reticulum. And it's known that many mutations alter the calcium flux out of the terminal sarcoplasmic reticulum. So one can do cell-based modeling of the RYR1 variants as a means of testing their potential impact on the protein as a surrogate for saying whether the variant itself is considered to be pathogenic. That may not still give you the answer as to whether it's disease-causing, but it may help add further clarification about the relative pathogenicity of the variant. Even with the availability of cell modeling in animal models, it's still possible that a variant may not be able to be classified, either because one doesn't have the time or money or technical availability to do these studies, or it may be that there just really isn't a sufficient modeling system to provide this clarity. So if one is still left at the end of the road, as it were, without clarification of a variant, we recommend the following. One is to reanalyze the sequencing data on a yearly basis, because often variants will, classification will change based on knowledge of other patients or functional data that's come out. Another is to consider additional clinical testing, genetic testing, if they were not done previously. So for example, if the patient had a gene panel, perhaps then pursuing whole exome sequencing would make sense if one was only left with a variant of unknown significance from the gene panel that one couldn't confidently say was the cause of disease. And then the final option is to consider research-based investigations to further explore causes, such as Kim mentioned, a whole genome sequencing, which when paired with RNA sequencing is a quite powerful modality. So these are just some of the types of validation studies that we are able to do and many labs can do on myotubes derived from patient fibroblasts or else on C2, C12 cells, which are a murine form of myoblasts that can be genetically manipulated to model patient mutations. We've also done a lot of work in terms of using zebrafish as a modality for validating sequencing variants. And we have a core facility that can entertain projects that can be used and dedicated to evaluating variants of unknown significance, provided there's a suitable outcome measure in the fish to provide clarification of the variant's impact. It's also good to note at this point that there are some granting mechanisms available through Genome Canada, something called the RDMM, or Rare Disease Models and Mutations granting mechanism, which can facilitate such projects to make and model variants of interest. So just to summarize, variants of unknown significance are an important issue in neuromuscular disease, particularly because of commonly associated disease genes with common variability, such as RYR1, NEB, titin, and collagen 6. Variants can often be clarified by additional clinical investigations. So clinical phenotyping is critically important in this regard and can often be well supported by MRI, biopsy, and EMG nerve conduction studies. At times, functional studies may be required to prove the pathogenicity of a variant. These are relatively limited by technologic availability and researcher preference and interest, but can be a powerful way of stratifying a variant. So just to let you know the resolution of the case I presented, we actually did move on to whole exome sequencing because we felt the Dynamin 2 mutation was not, a Dynamin 2 variant was not the cause of disease because the individual did not have a consistent clinical phenotype and did not manifest ophthalmoparesis, and that the MYH7 variant was likely not disease associated because the individual did not have distal weakness, did not have the classical toe drops seen with MYH7, and did not have joint contractures. We did a muscle MRI, which also did not show a pattern consistent with MYH7 or Dynamin 2. The individual had a non-specific biopsy, and we eventually moved to whole exome sequencing, where we found biallelic variants in the SCN4A gene, which is now a well-known cause of congenital myopathy, but at the time was a novel disease-associated gene, which we were able to provide further clarity based on a recent publication that had come out at the time we did the exome sequencing, as well as some functional studies that were performed on modeling the variants in a cell culture system. So I think with that, I'm going to stop, though I will say that if you do have individuals where you've gone through all of the testing and no answer has been found, there's a Canada-wide initiative called Care for Rare Solve, which is designed to help find diagnoses in settings where conventional genetic testing, such as gene panels and exome, have not succeeded. So with that, I will stop, and I will end my slideshow and go to the questions. Are there any questions? Yes, looks like there are. Okay. Do we accept samples from other centers for variants? So the answer generally is yes, depending on the nature of the analysis that would be likely. I'm very happy to always entertain questions about how to best evaluate a variant of unknown significance and to see if there's a relevant research-based methodology that could help provide clarity. If it's a question of RNA sequencing, we are certainly welcoming cases to put through our developing diagnostic platform. But if it's other functional type analyses, it would really be more on a case-by-case basis. And I'm very happy to entertain questions. I can put my I think my email is available, or I can just put it in the chat for everyone to see in case you want to reach out to me and ask questions. Okay. Lauren asked about RNA studies on DMD. We were able to perform the mRNA studies because the variant altered the RNA in a way that we could detect the differences between the two alleles. From one allele, we got normal DMD RNA, and from the other, we could see this insertion deletion change that the intron, I think there was an insertion of sequence, so we were able to see that in heterozygosity. So essentially as if there would be an insertion in genomic sequence. Oh, and Lauren also asked what the #1 gene was. You know what? I don't now remember. I read the paper when I was in my office, and then I got home and I couldn't find the citation again. So I'll find that and send it out to everyone. It's kind of interesting because the paper went through all of the different variants of unknown significance, the top genes, and just talked generally about the burden of variants of unknown significance across the genome. So Lauren, I'll get that. I think it's also important to mention, we're talking about Titin, that there's data coming out now that it's likely the second most common cause of congenital myopathy overall. And this is, I'm talking about sort of the biallelic recessive form of Titin. So I think this is going to be something that we're going to be dealing with more and more. And it's challenging on many respects. And one is that there is really no sort of signature histopathology that we can associate with Titin, unlike some other genes. So another question, if you have a VUS, how wide is your search net for second family? How is that facilitated? That's a great question. And I unfortunately didn't mention the matchmaker programs. So there's different ways to go about trying to search for other families. There are a fleet of matchmaker programs which help link your clinical cases with others across the world. Kim, I don't know if you want to chime in and say 2 words about the matchmaking programs that are available. And also, depending on where you do your gene sequencing, some of the companies will automatically reposit your patient into matchmaking programs. So for example, we do our exomes primarily at GeneDx, and they always reposit unsolved cases into their matchmaker program. So Kim, did you want to just quickly mention the matchmaking programs in Canada?
Sure. So there's many different programs that you can enter your patient into, and some of them are need very little information, where you can just enter even just a gene and looking for other patients who have variants within that gene. Some can be specific to certain variants, and others you can provide even more clinical information. So one of the ones that were developed at Sick Kids was Phenome Central. And so that one, because you are providing quite a bit of phenotypic information typically, does require consent from the patient, which is available through the online system when you go through to enter your patient's information. So really depending on the amount of information you want to include and help better to find a match, you can choose some of the different programs, and they all actually speak to each other. So you can get quite a bit of information by entering your patient into any of the different matchmaker exchange programs.
Okay, another question, how well is genetic diagnosis performed across the different provinces? Are there differences? So I may need some help from individuals from other provinces who are still on the phone or on the webinar. So for Ontario, I think we have a fairly privileged situation in terms of our access to genetic testing. The ability to get gene panels has been fairly robust. And in many cases, exome sequencing is approved for neuromuscular patients. So I think within the confines of the availability, we have a pretty broad ability to get testing in Ontario. I have heard that is variable across other provinces, and that I think perhaps in Alberta, sometimes that there's more of a restriction on access to things like whole exome sequencing, but maybe someone else, non-Ontario, who's still on the webinar might be able to chime in. Either, I don't maybe have to type into the chat. Or Lauren or Kim, do you have any insight from the other provinces?
Yeah, from my understanding, it's different across the different provinces. The process of how to obtain genetic testing is different. So ours, there's an application process that goes through the Ministry of Health, and there's a group that reviews those requests and provides approvals. In other provinces, you have to go through a specific genetics clinic and sometimes a consultation with that clinic depending on their process, or sometimes it can be facilitated across provinces depending on the recommendations and the requirements. But my understanding is the access to genetic testing can be quite different across the provinces depending on the budget of the ministry in the different provinces and what is available as well. Because a lot of the tests for panels and for whole exome sequencing are still needing to be sent out of country. And so that can be quite expensive, and it really depends on the province and their budget especially.
Okay, thanks for all the, Cheryl, are you able to, I don't know if we can give you access to.
I'll go ahead and grant access.
Okay.
It should work now. Dr. Greenberg, I think it's on. You just need to unmute. There we go. You can hear me? Hi.
Perfect, yes.
All right, thanks for a great session. I really enjoyed it. It's similar in Manitoba. We have a special genomic send-out committee that is run through Shared Health Manitoba, our provincial health network. So you do have to apply for permission to send out for exome, or in most cases in panels as well. Although it is limited by budget, if a child needs an exome, or if we feel that an exome is indicated, the committee will usually approve it and it will get sent out. So, you know, that's increasing more and more all the time, and the budget can only go up. And gradually our own DNA diagnostics lab, you know, through Genomics, is moving to more and more its own omics panel, you know, particularly for our founder mutations in our founding population. So it's transitioning more and more to an omics approach for many of our patients. But it's definitely both time consuming, and there's often lots and lots of delays for routine approvals for send-outs, even urgent send-outs, although it may be approved immediately, we may still wait 3 to 6 months to get results. And if you add mitochondrial DNA sequencing on top of it, it's quite a lengthy procedure. So I'm sure over the next little while, we'll find better ways to be able to deliver this kind of service to our patients. Okay.
Great. Thanks, Cheryl. That was really helpful.
Thank you. Thank you.
And I should mention that I think there are multiple provinces that are hoping to move towards in-province testing platforms. So I know, for example, Ontario is looking to repatriate genomic sequencing, whether it's whole exome or whole genome, I think is still to be decided.
I think that's the answer. You know, a made in Canada solution for lots of this. Yeah.
Yeah, agreed. Great. Thank you. I think on that note, we'll wrap things up. I want to thank the speakers, Arnon, Kim, and Lauren. All did amazing job presenting these topics in a very succinct and I think very accessible fashion. So thank you, all three of you, for giving of your time, and for everyone for your participation. And look forward to everyone participating in the next webinar, which will be in approximately 1 month's time.